In the area of foot and ankle, ankle sprain and ankle instability is the most common and the most important. It is said that there is an ankle sprain that happens in America every 30 seconds during the day. Up to 2 million patients will have ankle sprains per year, and it is very common in sports, even in athletic and professional sports. The ankle sprain is most commonly inversion type sprain, which is turning in of the foot, but there is eversion sprain as well that we will talk about. An ankle sprain can lead to ankle instability, and you can measure ankle instability by asking the patient to stand on one leg and balance, and standing on the other leg and balance, and you measure the time it takes to stabilize. Some of these patients cannot stabilize at all. You can always also do it with a machine. There is a machine, this is called a stabilometer. And it measures the time it takes to stabilize. So ankle instability can happen, and it is very important for you to look at the patient and see if they have hindfoot varus. Inversion of the heel is a precursor to ankle instability. There is a CT study looking at varus hindfoot in patients who are unstable versus control, and clearly if you have a varus hindfoot, you will have more instability of the ankle. So it is very important for us to look for it. It is also very important for us to know where the ligaments are. The CFL arises from the calcaneus and inserts into the front of the tip of the fibula. The ATFL arises above that and inserts into the talus. And this has been studied, and there is a paper by Burks and Morgan that will tell you exactly how to look at it. The subtalar joint also has a very important ligaments, the most important of which is the interosseous ligament. This is the interosseous ligament. It's between the calcaneus and the talus, deep in the sinus tarsi. If this is injured, you get subtalar instability. The rest is not as important. This is the cervical ligament, and this is the extensor retinaculum. If you have subtalar instability and you do stress views, you can see that the posterior facet opens up. And if it opens up more than 77 degrees, it is positive. Those patients that have subtalar instability will come to your office and say they have ankle instability. They don't know. And if you ask them if they have pain over their sinus tarsi, you will find that this is a common area, sinus tarsi tenderness. There is a provocative test described by Thurman in '97, where you dorsiflex the foot, you lock the talus into the ankle, and then you stress the calcaneus into varus, and if they have pain, that is subtalar instability. So look for it. How about imaging? Do we do an MRI on every ankle instability or ankle sprain we have? The answer is no, but sometimes we have to. Clicking, catching, locking, perineal tears, fracture, do an MRI. Can you prevent the injury or minimize the chance of an ankle sprain? The answer is yes. If you give them a brace, it works well, and that is why a lot of the professional sports and professional athletes will wear ankle braces. And this is a laced up brace, and it works very well. If you decide to treat someone with surgery because they failed conservative treatment, 80% of patients will do well with the conservative treatment. 20% will need surgery. You have to do an ankle arthroscopy at the same time. It is recommended because there's a high incidence of chondral damage, high incidence of OCD, high incidence of loose bodies. And if you don't, the patient may continue to have pain. The most common surgery performed for ankle instability is
Thank you, Professor Sameh, for your nice lecture. I'm asking about the repair of meniscal repair in adolescents. Meniscal repair in adolescents. The proper timing when I am late and when I'm early. The proper timing, when I am early and when I am late.
The distal, how to do it?
Meniscal repair.
Meniscal repair, yes. In adolescence.
Yeah. Timing, the proper timing. When I am late and when I'm early, and when I'm early, what you do, and when I'm late, what you prefer to do much.
So the patient presents with a meniscus injury, which is usually a twisting injury. You get an MRI. If the MRI shows a bucket handle tear, then this child goes to surgery right away. There's no discussion, especially if there's locking. If it's a radial tear, if it's a small tear, less than 2 centimeters, and they have no mechanical symptoms, we wait. We wait for 6 weeks. If patients do not improve significantly after 6 weeks, we do an arthroscopy. And if a child has a peripheral component to the tear, we repair it. The Chicago group in Rush are repairing everybody, radial tears. Bucket handles, of course, beak tears, flap tears, they're repairing everybody. And there's some evidence that it does heal.
How do you repair the interosseous talocalcaneal ligament?
The
Interosseous talocalcaneal ligament.
So the interosseous talocalcaneal ligament is the most important ligament in a subtalar instability. There is a Japanese procedure where you drill through the talus and drill through the calcaneus and pass a ligament. I have never done it. I trained with John Gould, and what he does is, and what I do, is you still repair the calcaneofibular ligament, and then you do a Gould modification. You bring the extensor retinaculum and repair it to the distal fibula. So I do a Brostrom Gould, and it stabilizes the subtalar joint at the same time. But there is a Japanese procedure that is described in the literature. I don't know anyone that does it. Yes, sir.
About the meniscal tears follow up by MRI. Is it when we follow up a case with meniscal tear, we don't have a clue. We have it's always the lesion is there. How you follow up the meniscal tear by MRI?
Do you mean follow up after repair or without surgery?
After repair.
So there are 2 papers that looked at healing of the meniscus on an MRI. An old paper by a guy called Metava. And he said you cannot predict an MRI repair on MRI. But there is a recent paper out of HSS, Hospital for Special Surgery, by Hollis Potter. Potter is her name. It's 2014. And she says that you can detect healing and you can detect stability in a meniscus on an MRI. Look it up, AJSM, Hollis Potter, 2014.
Any more questions? Thank you very much, Sameh. It's been a pleasure to have you with us.